Good morning, good afternoon, good evening, wherever you are. Thank you for joining us for today's webinar on the Family Planning High Impact Practice on Social Accountability. My name is Christine Gallavati, and I work in global family planning with the Bill and Melinda Gates Foundation based in Seattle, Washington. And I'll be your host for today's session. So let me just quickly review today's agenda. After a brief overview on what the high impact practices are, or the HIPs as we call them, we'll hear from USAID with a global perspective on social accountability. I'll then present a more detailed overview of the HIP brief on social accountability in family planning. This will be followed by a dialogue with two panelists, one from Tanzania and one from India, who will share their experiences working in this space. After this, we'll have about 15 minutes for questions from the audience before closing. So be assured that there'll be some time for you to ask questions. Before we begin, I want to let everyone know that this webinar will be recorded, and that recording will be available after the webinar. And you can submit questions anytime using the control panel on the right-hand side of your screen, where you will see an option to submit questions. We'll be monitoring the questions and we'll do our best to answer them either online or during the Q&A session at the end of the presentations. Also, please see the link on the screen in front of you, where you can find the HIP brief and get more information about the HIP partnership and other resources and tools. Also, please do download the handouts that have been provided. And you can see there's a handout tab on the panel on the right of your screen as well. So let me begin. What are the high impact practices? High impact practices are a set of evidence-based family planning practices that are identified and vetted by a group of technical experts in family planning on an ongoing basis. This independent technical advisory group works together to determine whether there is enough high-quality evidence on the effectiveness of the practice across a range of settings to be considered a high impact practice in family planning. And this evidence ranges, a practice can be either promising or proven. And if they determine it is, a process of developing a brief describing the practice, documenting the impact, and sharing tips on how to implement it is developed with support from implementing partners and researchers experienced with the practice. Importantly, the brief is designed to be accessible and easy to use for policymakers and implementers in the field to facilitate the dissemination and implementation of evidence-based practices. The high impact practices in family planning, HIPs, were first created in 2010 after a survey of FP stakeholders revealed that little consensus for what works in international family planning programming existed. And a small group of leaders in family planning were brought together with the task of identifying a short list of HIPs that they felt, if implemented at scale, would help countries address the need of the unmet need for family planning, and thereby increase national contraceptive prevalence. HIPs are identified based on demonstrated magnitude of impact on contraceptive use and the potential for application in a wide range of settings. And consideration is also given to other relevant outcome measures, as well as about evidence on the replicability, scalability, sustainability, and cost effectiveness of the practice. There are three categories of HIPs. Next slide. Enabling environment, service delivery, and social and behavior change. The enabling environment, which is where the social accountability HIP fits, address systematic barriers that affect individuals' ability to access family planning information and services. The service delivery HIPs are about improving the availability, accessibility, acceptability, and quality of family planning services. The social and behavior change HIPs focus on influencing knowledge, beliefs, behaviors, and social norms associated with family planning. And there's also something called a HIP enhancement. And a HIP enhancement is a tool or an approach that's not a standalone practice like the HIPs, but it's rather something that's used in conjunction with a HIP to maximize the impact of implementation or to increase the reach and access for a specific audience, like adolescents. And there's a different standard of evidence used to identify the HIP enhancements. Next slide. And here's a list of the promising and proven HIPs in each category. And I won't go through them, but you can see there's quite a number of HIPs in each category. And these are accessible on the website. All the HIPs are now available in English, Spanish, French, and Portuguese, and you can download them from the website. The HIP are supported by over 65 organizations that support and help disseminate these practices. So please do check out the website. It can guide you to all of these resources. Next slide. Today, we have 3 distinguished panelists who will share their experience and perspectives on social accountability with us. Dr. Sarah Safi, Ms. Alice Monyo, and Dr. Sita Sekar. Dr. Safi is the Senior Clinical Technical Advisor in the Service Delivery Improvement Division of the Population Reproductive Health Department of USAID. Sarah is a medical doctor and public health strategist and is here today to share a global perspective on social accountability and family planning. So Sarah, I'm going to turn it over to you.
Thank you very much, Christine. Hi, good morning, everyone. Good evening. Hello to you all from wherever you've joined. And thank you so much to Christine and Ados and all the organizers of this webinar for this opportunity to highlight the global perspective on this important topic. USAID Global Health is working on a broad spectrum of interventions related to social accountability and has an overarching approach to increase community voice while working on improving various aspects of the health system, including family planning and maternal health. USAID missions at country level and USAID Washington through programs managed by global health offices are exploring the role of social accountability in advancing respectful maternity care and respectful care overall in several continents of the world. Preliminary results indicate that expanding the community scorecard approach is a powerful tool for facilitating community feedback and communication with the health system to improve the quality of RMN-CAH service delivery and promote respectful maternity care. Yet there's a need to further understand the links between respectful care, quality of care, community voice, and social accountability. USAID promotes the use of a whole-of-system approach and social accountability programs advancing RMN-CAH, yet our projects work in 5 overarching thematic areas. USAID encourages governments and policymakers at all levels to establish an enabling environment for social accountability across government systems and with communities. This involves developing supportive policies and strategies for social accountability in the health sector from the national to local government levels and the encouragement of CSOs, including youth champions, community leaders, the media and community members to participate in regular key health sector activities such as budget hearings, service co-design and monitoring, and forums to set up to facilitate uptake of key health interventions. USAID prioritizes addressing the demand side and promoting social and behavior change. Meanwhile, we have specific activities designed to promote social behavior change with a focus on women's voice and agency, male engagement, and youth empowerment. These efforts require both community education and awareness raising, as well as community engagement in the design of family planning and maternal health services that are more responsive to community needs. It's important to highlight that USAID Global Health projects, social accountability interventions are complementary to our work to improve experience of care, respectful maternity care, and quality of care. We conduct research, generate data, and reviewed evidence on the effects of social accountability interventions, such as the community scorecard process, on promotion of respectful care. The process helps to identify and address barriers and drivers of family planning uptake and increase reproductive health-related trust and accountability between facilities, providers, and community and clients. In turn, the learning and actions promote health outcomes based on trust and accountability. In addition, USAID promotes implementation research to create a platform for social accountability researchers and implementers to share and identify emerging practices, lessons learned, and adaptation in social accountability. Meanwhile, USAID works on advancing access to care and conducts landscape assessment, mapping, and refinement of community partnership models for underserved communities based on the evolved understanding of community definitions in the context of immediate COVID-19 environment and longer-term equity objectives. To conclude, USAID Global Health projects are working extensively across the various levels of health system, including the national and subnational governments, policymakers, CSOs, local organizations, faith-based organizations, and communities to shape favorable policies and support and advance social accountability mechanisms in the local areas where we work to advance maternal health and family planning. We collaborate with CSOs and other groups to advocate for policy or programmatic changes that meet community needs. We have capacitated CSOs and or communities to utilize data, create coalition, cultivate relationships, conduct political economy analysis, facilitate dialogue, and more. They would use these new skills to advocate for policy changes that engender good governance practices at the community and health clinic levels. Thank you very much, and over to you, Christine.
Thank you, Sarah. That was very helpful. So now let me turn to the high impact practice brief we're focusing on today, social accountability. A practice we define as one that engages communities and health sector actors in a collaborative process to jointly identify problems and to implement and monitor solutions to hold each other accountable for improvements in quality and responsiveness of family planning services. Social accountability is generally understood as collective efforts of individuals and communities or rights holders, next slide, to hold service providers, government officials, and other decision makers, also known as duty bearers, to account for the quality, effectiveness, and equitable provision of services. It's been used for many years across many sectors, and it's an evolving umbrella term that is used to cover a wide range of approaches. But the social accountability practice described in this brief is one that the technical advisory group determined had the most evidence of effectiveness on family planning related outcomes. So these approaches are distinguished by the following key characteristics. Next slide. They primarily operate at the subnational level, where the community and the facility intersect. They involve a high degree of community influence and control, are largely collaborative and confrontational. They facilitate community voice and bolster service provider responsiveness. And they're structured, facilitated, and transparent processes that try to create safe and inclusive space for effective dialogue and negotiation. So what does this practice look like? The process often starts with a non-governmental or local civil society organization initiating conversations with key health system stakeholders, during which the benefits of increasing dialogue between the community and health workers is shared, and their support and co-ownership is garnered. Next, a series of facilitated discussions with the community members, including key groups like women, youth, marginalized people, are convened to solicit concerns, discuss barriers to service, and prioritize areas of most concern. A series of facilitated discussions is also held with health providers to give them the opportunity to voice their concerns as well, and to prioritize the biggest problems from their perspective. Once all stakeholders have had a chance to be fully heard, an interface meeting can be held where each side shares challenges and concerns, and together they prioritize the issues to tackle and discuss how to do so. At regular intervals, they then come back together to jointly review progress in an ongoing accountability process. There are a number of both branded and generic tools and approaches that follow this basic process. For example, as Sarah mentioned, community scorecards, citizen voice and action, social audits, and there are additional resources available in a link in the HIP brief if you're interested in learning more or getting access to those tools. And in fact, I think we have some in the handouts as well. To give you just one example, this next slide graphic shows you how the community scorecard works. As I've just described, it starts with a series of facilitated discussions with community members and service providers separately. And then following those discussions, the concerns raised are consolidated into a set of 10 or 15 indicators, and each indicator is given a score. Next slide. Here's an example of a scorecard from a community meeting. Next slide. Yeah, there it is. In the left column are the indicators that the community identified as a way to measure the issues that emerge from the discussion. And so each indicator is given a score from 0 to 100, with 100 being, as good as it can get, no improvements needed. And then in addition to the numerical scores, participants provide reasons for these scores. So for example, you see indicator 8 is relationship between providers and communities. And in this case, they gave it a score of 20, a low score. And the reason for that score was the community said the health provider treats them rudely or without compassion. Now, a similar indicator could emerge from the provider's discussions, and they could also score it 20 out of 100. But their reasons might be quite different. They might say the relationship was poor because clients don't listen to them or follow their instructions. So anyway, this is how that process works. And then the community, health providers, and local officials come together in an interface meeting to compare their scores, discuss the issues, and develop a joint scorecard and an action plan. They then implement the plans and regularly reconvene, usually like every 6 months, to monitor progress. So next slide. Here's an example from Malawi of the way they jointly tracked progress from a community scorecard process. And as you can see, all of these indicators showed substantial improvement over time. Next, I want to turn to the theory of change from the high impact practice brief. This describes some of the challenges that this tip can help address. So on the left, you see some of these challenges. Services that are not well aligned with community needs, negative attitudes, for example, of service providers, or just a lack of resources, power imbalances and inequities in family planning resources, lack of awareness of citizens of their rights and entitlements, as well as lack of awareness on the part of providers, a lack of trust in the health system that might discourage clients from accessing services, and unsupportive norms at the household, community, and facility level can be a major barrier for many people to exercise their rights to family planning, especially adolescents, unmarried, or newly married couples who may be feeling pressure to prove fertility, for example. The middle column describes how the HIP works through an inclusive, facilitated process. Social accountability tries to increase understanding of rights, and in some cases challenge norms that may constrain people's ability to make reproductive choices and access services, tries to promote dialogue and negotiation, and focuses on joint problem identification and resolution and monitoring of improvements, and then hopes to achieve the outcomes on the right. So what is the impact that's been seen? Next slide. There's been a lot of positive experience with social accountability processes over the last several years, and we're learning more and more about how these processes can disrupt and realign the governance structures and systems that affect an individual's ability to access family planning information and services, resulting in services that are of higher quality and more responsive to clients' needs, improved client experience and satisfaction, increased access to and utilization of family planning services, and increased trust between the community and the health system. Next slide. And so the last slide I want to leave you with to say that measuring the impact of social accountability is challenging, given its complexity, and more research on how it supports family planning outcomes and under what conditions is definitely warranted. Some key social accountability indicators recommended by the HIP Technical Advisory Group to measure participation, inclusion, and experience of care are these following ones. The percent of the community that have a functional mechanism for engaging communities in the design and the implementation and the monitoring of family planning service delivery, and the percent or number of women or marginalized groups who participate in those accountability mechanisms. And then a final one is the experience of care, that clients in the catchment area with these mechanisms experience an improved quality of care that is respectful and responsive to their family planning needs. And this indicator or similar ones might be captured through regularly implemented scorecards or facility-based data collection systems, or even through surveys. So please do refer to the brief for more information. And of course, we'll have questions at the end. But now, and here are some of the resources I mentioned. We're going to turn to our two panelists who are going to share their perspective and experiences with social accountability with us. So next slide. Alice Monyo is the Director of Programs at Sakika in Tanzania. She is a social scientist with experience in health policy, evidence-based advocacy, community engagement, governance and accountability, and has led several social accountability interventions in the health and family planning sector. And unfortunately, Alice is here with us, but her camera is not working. So you will hear her, but unfortunately you will not see her. And second is Dr. Sita Sekar. Dr. Sekar has a doctorate in econometrics and gender studies. Hello. And is currently an independent global consultant in governance and social accountability tools. Her clients include the World Bank, WHO, UN Women, among others. And she was formerly head of participatory governance research at Public Affairs Center and executive director, Public Affairs Foundation, Bangalore. So thank you both so much for being with us today. Sita, let me start with you. We know that it can be very challenging to facilitate dialogue between citizens and duty bearers. So how do you keep it positive and productive and avoid finger pointing? Can you tell us anything about, the challenges of facilitating this dialogue and any tips you have for keeping it productive?
Sure. So there are, of course, many challenges, and you mentioned some of them already, Chris. So I'll just have 4 that I thought were very critical. So we have one big challenge is, like you said, the lack of awareness of entitlements and responsibilities, the lack of trust on both sides. While citizens think that they are entitled to services, duty bearers view it as doles or alms that they are giving. And making them understand their roles is something that is one of the challenges that we face. Unpredictability of the tenure or officials is something that I think most organizations that are involved in social accountability sector face. Every time an official is posted out, we have to go along and build the rapport, relationship, and trust all over again. So that's another challenge. Another is the absence of a systemic communication channel between citizens and service providers in many cases. This makes them wary of each other and brings a confrontational attitude. While duty bearers ignore and avoid citizens resort to protests or are suspicious of the duty bearers. One very important thing is that the concept of the stakeholder is missing in in the whole narrative or conversation that happens between service providers and the users of services. So people do not think that they're all stakeholders, and they do not work towards collaborative efforts to bring improved services. The second part of your question was about how we keep it positive and productive and avoid finger pointing, right? So very quick tips. If you have separate orientation and rapport building meetings with both entities, giving examples of how it has helped others like them in other places, in different countries, different scenarios within the country, and so on. So that helps. Keeping the focus on positive outcomes and how they benefit both duty bearers and the citizens is another useful tactic. Social accountability tools such as citizen report cards, community scorecards, citizen voice in action, disability inclusive scorecards are all designed to encourage a collaborative approach. So finger pointing actually does not happen in these methodologies when they are used generally. Using social accountability tools helps in identifying problems and issues, and then solutions are arrived at through a consensus process, so which is acceptable to both sides, and there is no contentious dialogue happening. Use of the help of local leaders and knowledgeable members of the community would also help ease the effort of conducting or using a social accountability tool. One tip is that we keep, initially at least, we keep government officials or authoritative figures out of our discussions with the community, because sometimes there is a certain amount of power play happening or bullying happening, so people are not able to speak freely. So it's important to have a meeting with the community members without any authoritative government entities being present. Since these approaches are all data driven and evidence based and not anecdotal, the acceptance among both community and the service providers is better, because there's no finger pointing happening on any one particular individual. So this is what I would say in response to your question. Thank you.
Thank you. That's very interesting. Alice, what can you say about that? Do you have anything to add or any examples?
Maybe a few. Thank you, Christine. Just one or two additional points. One, I will say, what we have learned over the time of implementing the scorecard, it's important to introduce the approach, the social accountability intervention in the community, and ensure that all stakeholders understand the approach, meaning the citizen, the duty bearer, service providers, the council or facility health management teams, so that once each one understands the whole approach, why are we doing that, the objective, the methodology, as Sita said, even the role of which in the process, it helps to keep the dialogue positive and productive, because everyone understands this is to ensure that at the end of the day we have quality provision of quality services at the clinic or the primary health facilities. But again, there's a whole issue of good facilitation, because it is good facilitation is critical for creating a productive dialogues. Ensure that the facilitators understanding and they're neutral when it comes to leading these dialogues, providing ample time for each party to raise and clarify issues, so that each party or each partner in the dialogue understand what are the causes and jointly can propose the solution. So that kind of may avoid any conflict that may arise. For example, I will say service users may be concerned about the long waiting time at the maternal and neonatal clinics, and they may even provide some examples, some evidence that have been when I come to visit the clinic, I may spend 3 to 4 hours just waiting to get the service. But if we are giving time, the healthcare providers may come up with the reason, may come up with the causes for that. Maybe they are not adequate healthcare providers, and together they may be able to try to find a solution, or just raising the issue to the council management team for additional staff. So all this may help to minimize the challenge during the dialogue, but also keep this dialogue positive and productive. Thank you.
Great, thank you. That's very helpful. So Alice, staying with you for a minute, could you say more about how you approach discussions about sensitive topics like family planning, sexual and reproductive health, particularly maybe around issues when you're talking about adolescence and family planning with communities? How do you deal with that when you're working in this area?
I will say it is important to understand the community, even if we are working in Tanzania, but different communities have different beliefs, culture, and traditions. There are some which women can talk when men are around. There are others which women cannot talk, cannot discuss this issue, or men cannot talk about sexual health when women are around. So it's very important that the facilitators, the implementers, should understand the community and the culture and tradition. But again, implementers, they may check if there are guidelines or policies that by the government that they can use, because that may give some direction and may help to for implementers to plan well before they engage. Also, it's important to consider also learning from who have been implementing similar projects, similar intervention before your intervention, and also learn about who are the key influencers in the community, and you may be able to consult them before the implementation. It will provide some ideas on how best now you can discuss this sensitive issue within the community. As I said earlier, that different communities have different beliefs and also the culture and the traditions. But again, strategies like separating groups based on sex and age can make participants discuss freely. And also this goes in hand with facilitators. Maybe the women may prefer to have a female facilitator, or men can prefer to have a men facilitators, as the age and sex of the facilitators may influence discussion positively or negatively. So this, I will say, these are kind of issues someone may need to look or to plan well before they engage in discussing sensitive issues.
Okay, thank you. Sita, do you have anything to add about that? And do you think social accountability approaches are, can contribute to helping facilitate some of these discussions on some of these sensitive topics? Well, I think you're on mute.
Sorry about that. Yeah, so just like Alice said, many of the points that I have are similar to what Alice said, but it's important to have gender segregated groups to deal with issues, especially where the social structure is such that women are hesitant to speak freely, especially in the presence of men or other people. So it's important. And like you asked about adolescents, so we have done exercises where we've spoken to adolescent girls about their experiences and their knowledge about sex education that's given to them, and tablets, iron tablets, and so on. They are very, very hesitant to even go to the health center, and it takes a lot of effort to cajole and convince and talk to them to have them open up and talk to you. So it's very important to have someone who is a woman, who understands what they're going through, and is able to make them comfortable. So apart from the other things, like she said, about building trust and talking respectfully to show an understanding of their circumstances, making oneself familiar with local social norms and all of these things. Another way out would be to use methods such as street plays and role play, so that the community is better engaged and people feel less shy to talk about. And this is something that we had used in the context of use of toilets in a project that we did in India, and that really helped for them to see their experiences being played out on the stage, and then they felt comfortable talking about those things. So that's some of the solutions that I had.
Yeah. Okay, great. Thank you. Okay, well, let me talk about a kind of different issue, which is about measuring and monitoring changes that result from social accountability processes. As I said, some of these changes are difficult to measure and monitor. How do we know when they've been successful? What does success look like, and how do we really measure that? What are your thoughts about that?
Yeah, so there are some approaches that used, quantitative methods, like the citizen report cards uses quantitative methods where you measure satisfaction, you have ratings for satisfaction, you measure the improvement or percentage terms, how access has improved, and the number of right to information applications filed, um, provision of family planning material and things like that through a survey process. There are also qualitative methods that are used that measure changes in awareness, in attitude, and also the extent of collaboration that happens between the duty bearers and the citizens. And I could give you some examples. There are hundreds of examples, but I can give you some examples so this becomes a little more clear. I mean, these impacts can be, these measurements can be done in different ways. So for example, one example is that of, there is a standard set menu that is given for provision of a midday meal in child care centers as well as in schools, in government schools in India. And after we conducted a community scorecard, even while we were in the process, we just visited the kitchen and spoke to the cook, and she was making something that was off the menu, and which was less nutritious for the children. And as soon as we went and asked her, and then went back to our discussion with the community and with the service providers, she called up the person who was in charge and told him there's something going on here and we really need to provide as per the menu. And one of the participants came and told me that, ma'am, we can already see impact. We can see impact. And we saw, and she had, added to the menu and prepared some things which were different and, more nutritious. She had been given the material to do that. So that's like an immediate impact or effect that we saw. So that's how we could measure how the community scorecard helped. And then there was another example of a child care center, which is also run by governments, where the mothers understood through this process, they were empowered and they felt that they have the right, or they are entitled to go and check the quality of the gruel that is being given to the children. And they did that, and in the meeting they said that it is very watery, it's not, does not have the quantity of lentils that it should, and so on. So as a result of that, the next day when they went for inspection, they found that the quality of the item had improved. So that's just a couple of quick examples of quick changes that happened. Agreement among, the understanding that they are working with each other and they need not be confrontational is something that results from these social accountability approaches. And then they start working together, they build a healthy relationship and they start working together. And in fact, it works so well that I'll give you an example of a citizen report card that we did, where we found that, the agencies that were rated and ranked started calling us and saying, so when is the next report card happening? We want to know our rank. We want to know whether we have performed better. So that brought in a kind of accountability and also interest among them to perform better and serve their citizens and clients better. So that was something that I could give as an example from India. And there's also examples of change in, using, when we have used the disability inclusive scorecard in Ghana, Nigeria, and in Senegal, we found that, that information that was provided as a part of the whole exercise to the citizens helped them to know what they are entitled to and what their rights are. And as far as the service providers are concerned, they understood that their behavior towards the women with disability is not what it should be, and they have started to behave better. They have understood. So that's, how you can measure, and you get the feedback from the people and they tell you that yes, their behavior has improved. So these are different measures that are used in improved infrastructure, changes in policy that happen. These are all, inclusion of social accountability tools like social audits that you mentioned. They have now become in one of the provinces in India, they have become part of the government's activities, that they carry out social audits regularly. So that is also something that happens as a result of our activities. And yeah, we have several examples, and I could go on and on, but let me stop there. Yeah.
Okay, great. Thank you. Alice, let me move on to our last question before we go to the audience for questions. So we've heard a lot about, and I know you've had a lot of experience with local level effects of social accountability processes. There's so many stories of these really wonderful examples of local level effects. But how do we scale social accountability impacts? Do you know, I mean, what are some strategies for scale or some examples? Do you have any examples of social accountability impacts that have been scaled or programs that have been scaled?
Oh, thank you, Christine. This has not been easy. As implementers, we have been always thinking on how to sustain and scale the impact of social accountability in the communities. Sometimes we are working with a few, actually most of the time we are working with a few facilities, and you see the result, and you like to see that these effects, goes beyond the facilities or the community that we are working. And some of the strategies, some of the strategies that we've been using is to engage the council health management teams, the local leaders, CBOs, and other stakeholders in the community. Aim is to ensure that they learn the process, they understand the outcomes or these effects. But again, for example, the council health management teams, once we share the action plan, they are able to use that during their routine supervision to work with the communities that we have been implementing social accountability intervention, and even beyond, and see how the progress the progress of these actions. But again, we have encouraged to use the existing structures when implementing this intervention. For example, when we are doing the community meetings, rather than organize meetings with the assistance from the local leaders, we have been asking, when is your next community meeting? And use these forums, these existing structures, to introduce and work with the community in the process. So even after the intervention is over, these structured communities and forums are there, and the people, once they have the skills, they continue. And that's, we see that somehow we are able to scale up the impact without depending on NGOs, CSOs to start or to facilitate these interventions. But again, we have been also working, although we are working with the whole community, but again, we've been asking the community to select at least 10 to 15 representatives from different groups, women, men, people with disabilities, young people, adolescents, and the like, to be part of the core facility. We call them SAM teams, social accountability teams, whereby they are the lead people, they are the lead team when implementing, and they are the one who will be also monitor the action plan and report to the entire community. So when this after few monitoring session, quarterly 2 or 3 session, you find them, they are able even to start a new intervention in the different communities. So this is how we've been trying to work to ensure that whatever we're learning in a small community, also we can scale the impact in another communities.
Interesting. Sita, you have anything to add to that? Any examples of scale in your experience?
Sure. So one example or one method, way of scaling up would be to do smaller initiatives. And I think to an extent, that is what Alice is also talking about, that you use the tools in several locations and then collate so that you can extrapolate to a larger geographical area, and also share these findings from the different smaller local efforts with higher level government, and that would then a different fora to help scale up. So there are two examples that I wanted to give. One is from Tanzania, where the Tanzania Social Action Fund conducted citizen report cards in 3 different districts, and then used some of those findings and conducted community scorecards in 20 villages across the 3 same districts. And these findings were then used to scale up to other districts as well. So that is something that's an example of how things were done. Another example I would like to give is that of Sight Savers India, who did who used the disability inclusive scorecard in 5 locations in India, and then used that experience to prepare a toolkit and a very descriptive manual that tells you how to use and what came out of it and so on. And that then helped in scaling up and spreading it across to other countries as well. And that is how Sight Savers in Ghana, Senegal, and Nigeria also picked this up, and using the manual and a little bit of support from my side, they conducted committee scorecards, disability inclusive scorecard in with respect to reproductive health care, family planning services, and also eye health care for women with disabilities. So these are a couple of examples that came to mind immediately.
Yeah. Wow. No, those are great examples. Thank you. So I don't see any questions from the audience, so we're going to continue our dialogue. If there are any questions, please put them in the question box and we will get to them. I'd like to continue then with the dialogue with our panelists and ask, as you, with your long experience in doing social accountability in health and in other areas, what do you think are, in terms of what you would like to see researchers do to strengthen our knowledge base around social accountability? Are there questions that you'd like to say to researchers, do more research in this area? Or do you think we know enough? Do you think we're now at a stage where we should just be focused on disseminating the practice and really doing more of this work? Or do you think there are some key research questions that still need to be addressed? And if so, what would they be? So I'll ask Alice, I'm going to start with you if you have any thoughts on that. And I'm sorry, I know I didn't give you this question in advance. So.
That's okay.
Okay.
Yeah, Alice, you want to go first?
Alice?
Okay, I think I'll start. Maybe she'll.
Thank you. Sorry, I was on
there you are.
mute.
Go ahead.
Yes, on mute. Okay.
Oh, happens to all of us.
I think the research, as implementers, we still have several questions. We have Sita has shared several examples that how this social accountability. You see the impact, you see things are changing, but sometimes you are not sure when and how it has changed. How is the contribution? And if we were working with the researchers, we would love to learn how does it work in terms of exactly when we are, let me take an example. You are working on family planning, and there are several issues that you have raised, including the infrastructure, the behavior, the enabling environment, the policies. And at the end of the intervention, at the end of your program, you see at least 5 or 10 indicators have worked out. But we would love to know as implementers so that we can be able to scale, we can be able to sustain these changes. Is it because of the intervention only, or are there other kind of confounding factors? That could be one. But again, sometimes you are working on the very same community, same project in different communities, but community one, you see the impact, you see the outcomes, you know, kind of right away in a short while. But in other community with the same dosage of the intervention, you don't see those changes. And you would love to learn, did I do anything wrong? Will I, you know, is there anything else I could have learned so that although it works on community A, but it didn't work so well on community B? Those kind of questions, as implementers, we still have, and we would love to learn more from the researchers.
Great, thank you.
Thank you. Documenting all the, you know, many of us as implementers are so intent on carrying out the whole exercise that we do not, you know, document everything that we do very carefully sometimes. So you're just saying, okay, these are the indicators that came up, and these are, but what about all the talking that happens? So whenever I'm doing training on community scorecards, I tell them, make notes on, you know, the dynamics among the group and what's happening. I'll give you an example where, you know, there was one of the conditions given that, you know, Water Users Association should have a woman member and a woman person from a lower caste included and so on. But actually the dynamic among these people is such, especially in rural areas in India, for example, and even in Africa to a certain extent, there is, you know, you will not speak in front of village elders, and if a person has higher social stature, you don't, you know, speak much in front of them. So how do we deal with those things? And these are all minor, you know, they may be sounding minor, but they are very important when you actually implement and try to come up with solutions to issues. And like Alice said, you have some places where you see immediate impact, and you know, you are extremely joyful and very happy that, oh, I did this and this happened. And other places, and exactly this happened with us also in one of the experiences in India, where, you know, one village that was rated the best, the community was very cohesive and they were very working together, and they came up with very good you know, activities that helped their local government perform better. And the other, there was a lot of dissonance, and therefore nothing much happened. The same intervention was used both places. Yes, sorry.
Okay, I'm going to have to stop you there. Thank you so much, both of you, for sharing your perspectives. It was really interesting. And we only have 1 minute left. So in the final minute, I just want to thank everyone again for your participation. Social accountability is a passion of mine because I think it can provide the foundation for a truly responsive, respectful, rights-based family planning program and support both service users, service providers, local officials, and policymakers in achieving their goals. I hope you all enjoyed today's webinar, and I encourage you to reach out with any additional questions. Please download the materials, go to the website. We are going to send you the recording and links to the website and additional resources. And again, thank you so much to our distinguished panel. for all of your insights and thoughts. We really appreciate it. And thank you very much. Bye.
Thank you. Bye.
Bye.